that I decided to do a little recap of the salient features of our last lesson because it was so dense. So let's review. Think of me as that little insect in the caption person. Eyeball. What's in front of the eyeball? Cornea and lens. What do they have in common?
No blood.
Ideally they should be crystal clear. No blood, no nerves. Their purpose is really to focus light from the outside, get it into the eye. Yeah. Many of us have had cataract surgeries. What is that? It's just the replacement of a lens. With age, it gets cloudy, or can get cloudy. The cataract surgery is just a replacement of that lens. The lens is popped out of the capsule. Nice new lens is put in. Then let there be light. Iris, you know about. It's like the f-stop on your camera. It sort of optimizes the amount of light to get in for vision. Then we hit what? We hit this squishy eyeball, a vitreous humor. What is that? Remember Mike's example of the Jello on the counter? When we're young, it's nice and firm. As we age, it starts to melt a little bit, get watery. One danger there is as it's melting, it might pull away from the retina. That's the one thing that I know about anyway, that might pull you away. Then, speaking like the sensory neuroanatomy science, we hit the retina, which is where the magic happens, or at least begins, right? What is the retina? It's all the sensory cells. Where is the retina? If this is your eyeball, it's all around. If this is the eyeball, it's all around. It's not just in the back of the eye. It's like a coat all around, except for the very front. So it's like a little network of nerve cells. What's the macula? Macula is in the center of that, and it's a concentration of cells. It's responsible for our vision, basically our central vision, our visual acuity. What's the fovea? People kept asking me that Sunday, except Thursday. What's the fovea? The fovea is in the center of the macula. How big's the macula? It's only about 5 millimeters. That's like, quarter of an inch, half a centimeter. The fovea is in the middle of that macula, and the cells have separated to make it even pinpoint clearer. No obstruction at all. That's only about 2 millimeters. Very tiny in the back of the eye. What else? What's the blind spot? Yeah. Blind spot's where your optic nerve goes from your eyeballs. What's the optic nerve? It's the tunnel. It's the conduit from your retina, your sensory cells, back to the brain. And it also, blood and nutrition going forward. Macula. We talked a lot about macular degeneration. A lot of us in here know personally about macular degeneration. What is it? It's that center vision macula. Usually it's AMD, right? Age-related macular degeneration. With age, you can get from a lot of different factors, disturbances in that macula. 2 types, dry and wet. Dry is the most common, 85% of MD is dry. What is that? Lots of people don't know about it until the retinologist tells them. But if they are aware, you've got a little squiggle in your central vision. So if you look at a straight line, it might not be perfectly straight. Wet MD. What's wet MD? Why is it called wet? When the disturbance in the back, when it's when it's really hungry for oxygen, the body will want to grow more blood vessels. And so the blood vessels will come through the retina to get it more oxygen. That disturbs your vision. That's not that common. I mean, 10% of MD, but it can lead to blindness. Dry MD usually doesn't. Wet MD, you need to pay attention. And really, until, 20 years ago, there was no treatment. You just went blind. I don't know, maybe 20 years ago, VEGF antagonists were commercialized. What's VEGF? What is VEGF? Vascular endothelial growth factor. It's a growth factor. Is it bad? Yeah, it's bad as adults usually because it enables cancer cells to grow sort of uncontrollably and metastasize. In utero and early age, it's critical. It's critical for brain development. So basically anti-VEGF are the medications now that are available to treat dry MD. It's revolutionary. And this is the eye injections that Mike was talking about. And if you want to know about eye injections, we are going there on our way to Vermont this afternoon so that Mark can get another eye injection. So what else? Any other highlights?
What she said.
Yes. Very good. Okay.
Thank you.
That's it.
Thanks, Jenna. I was going to do a little recap, but it's going to be like this is episode 2 of The Eye on Netflix, so we'll skip recap and we'll go where we kind of left off. I was going to start talking about glaucoma, and I kind of butchered it a little bit. So let's start it from the beginning. Glaucoma is high pressure in the eye that can damage the optic nerve. And the way it does that, it blocks the axonal flow of all the retinal ganglion cells that are making up the optic nerve from the retina, damage the optic nerve, and it causes cupping of the optic nerve.
It's really cold outside. I mean, drizzly. Drizzly. It won't be where you're going, but it is here.
So better let Barry know maybe. It is a little drizzly out there. And so if you have cupping of the optic nerve, that's one of the early clinical signs that you might have glaucoma or some damage to the optic nerve. So it's a pressure buildup. And how does it happen? We showed you that there was a drain of the eye, which is in the front between the iris and the cornea, and that's called the trabecular meshwork. Thanks to whoever said make your cursor bigger, because the first time I've ever done that. So yeah, that was fantastic. I can make it even bigger, but then it was unwieldy. But so in glaucoma, most glaucoma is that you've blocked the drain. That's just there's not very many problems in the eye where you're not making enough fluid, and the fluid's made by the ciliary body right there. The lens has zonules that we're going to talk about pretty soon, and that holds the capsule and the lens substance together. So there's a little area right here where the fluid comes around and then it drains out there. So let's go to the next slide and I'll show you that. Now, again, that's the trabecular meshwork. Remember, you needed a mirror to look at that because with total internal reflection, what's an optical law, you can't see into the corner of the eye without a mirror. But that's the drainage side. So we have these mirrored lenses. We look at that. And when you hear of open angle glaucoma, that means the angle's open visibly. It doesn't mean it's draining well. It just means you have an open pipe, but somewhere in that drainage side, it's blocked. And again, that meshwork is right there. Fluid produced here comes around here and goes out there. So there's a rarer forms of glaucoma that I don't want to get into too much. Pupillary block glaucoma, where the iris and the lens are blocking that flow of fluid. That's the angle closure, and then it presses the iris up against the cornea sometimes, or closes it. That's called angle closure glaucoma. Those are the people that aren't supposed to have antihistamines or cold medicines. But that's a smaller group. And we talked about Humphrey visual field testing, which is tedious. And you sit in front of that machine and little lights go on and you press a button when you see the light go on, and it's very unreliable a lot of times. Here's an example. There's your blind spot right here. And over here you have the blind spot and some glaucomatous damage, like an arcuate defect. And that's how we evaluate glaucoma. One way is a visual field. Now, if you have a cataract, it's going to be hard to get a good quality visual field. If you have diabetes, it's going to be hard to get a good quality visual field. If you had laser, so there's so many reasons that I didn't go into glaucoma, and those are just a few of them. And I did a bad job last time, but let's go over cup to disc ratio, because when you look at an optic nerve and you're in ophthalmology, you should be able to look at an optic nerve and go, oh, that's glaucoma, or that looks good. So here's a good looking optic nerve. It's got a lot of pink, orangish tissue. The edge of the nerve is here. That's the disc. We call it an optic disc, optic nerve, the papilla. There's all these names for everything. And then the cup is the area in the middle. Now, if you have a really big cup, that's like a 0.8 or a 0.9 cup to disc. It'll look more like that. Whereas if you have a smaller cup, it'll look like that. So that's just visual observation. And a good glaucoma specialist is looking at more than just cup to disc, but that's just the general idea there. So again, here's a larger cup to disc on the left, and on the right, you have a smaller one, which would be more normal. Left one would make you suspect glaucoma, but again, different races have different size cups. And a lot of times a cup like that can be perfectly normal. How do you determine that? You do a visual field, or you do a test like this, which is related to the OCT. So when you're sitting at that OCT, which we've gone over, some of these scans look similar, although this is an optic nerve scan, but it looks similar to the macular scans we were talking about earlier, same machine. So this machine revolutionized, retinal diagnosis, and it's also helped a lot with glaucoma. And the way it does it is it measures the thickness of the nerve fiber layer, which are all the retinal cells going to form the cable that's going to go back to the brain. So when you have pressure that pushes on those fibers, they thin out, you get a higher cup to disc ratio, and you start seeing thinning that shows up in a grid, because the machine can print it out and make it visual for us like that. So if you have a lot of red, that's bad. A lot of green is good. And so this is nice because it's a quick way. If you have a large cup to disc, you're wondering, is this physiologic? Is it a normal due to the race, or is it really a disease? You do a nerve fiber layer. We call it a retinal nerve fiber layer, and it's all green, and you go, okay, they're all right. And they don't have to go through. I won't send them for a visual field if they look like that. There's a lot of drops for glaucoma. I'm not going to go all over them, but there's got to be somebody in here that takes drops for glaucoma or just takes teardrops. So let me tell you the right way to take a teardrop. It's usually good to recline. 45 degrees is fine enough. Tilt your head back, pull the lower lid down, and then drop it in. And then the first normal reaction when something goes on your eye is to squeeze it out. That's not, if you're trying to put it in and you squeeze it out, it's going to go on the cheek. Another reaction is to blink a lot. Then you're pumping it through the punctum of the eye into the nose and down your throat. So closing your eye for a minute or two is a good way to absorb the medicine. If you really are worried about, let's say you're taking a beta blocker and you have asthma, but you need it for your glaucoma and you've tried other drops and you're still using it, it's called punctal occlusion, where you press on the lacrimal duct, and you block that output through the eye into the nose. So that's how you take an eye drop. So don't squeeze and blink a lot. Even if it stings, that's usually due to pH. There's certain glaucoma drops that'll sting the eye, but if you gently close your eye and take that severe pain, you'll be okay. So we talked about the four main problems of visual loss in people our age: cataract, glaucoma, diabetes, and macular degeneration. So we've covered a lot of macular degeneration. I want to talk a little bit about cataract. The lens is formed in embryogenesis by, yes?
Yeah, just before you moved off glaucoma, you didn't say anything today, at least, about low pressure glaucoma.
Yeah,
I wondered what that was.
Yeah, low pressure glaucoma is a myriad of things, but like I said last time, it's probably a big subset of that group is sleep apnea. Because the pressure's going high at night. When you come into the clinic, we measure it and there's, normal pressures. So that's been called low tension glaucoma.
There is high pressure at time.
Probably. There may be a true group of low tension glaucomas that we don't know what it is, maybe poor circulation or anatomical problems or weak collagen, but it's probably a lot of that group is sleep apnea. Yes.
You comment on diet and glaucoma. Are there relationships? Is it something?
Not that you can drink a really, really excessive amount of water and raise the pressure in your eye, but that's hard to do. Trumpet players are known to have glaucoma, trombone players, because they're. So like, remember what I told you, when you're asleep apnea and you're going. And my face is turning even redder than it normally is. That is raising your pressure. When you see a trombone player and they're going, and they're valsalving, so that is transmitting pressure through your venous system and raising your blood pressure sometimes too up to the eye. Yes.
Other than drops in your eye, can you do laser?
Yes, there's laser for glaucoma. You can laser the meshwork. For angle closure glaucoma, you can put a hole in the iris. But people are doing that less now and removing the lens. That was very common when we were young. I'd give somebody a laser to open up for angle closure. And now people are saying just take the lens out. But yeah, there are SLTs is one laser for glaucoma, but it's usually mildly effective and temporary. And there's surgeries for glaucoma where you make holes in the eyes or put stents in, but there's a myriad of those things. And the reason there's so many is because they don't work well. So like you make a hole in the eye, what's the problem with that? The eye heals it. The eye wants to make fibrous tissue and close up defects. So when you cut your skin, there's a lot of energy to bring things together and close them. Same thing with you make a hole in the eye. The interesting thing is you make a hole in the iris, it doesn't usually close over, which is pretty cool. But the iris is very special. It's made of neuroectoderm. It's one of the only muscles in the body that is made from neuroectoderm. If anybody's ever got interested in iridology, there's just like the ear for ear acupuncture or the foot for reflexology, the whole body's in the iris as a map. Actually, I was going to tell Jenna, if you like, I can save the bigger lecture that I have and send it to you on a drive and you could share it, or it could be shared with other people, because we never learned this all in 1 or 2 or 3 lectures. So, she did a great job kind of like summarizing it, but to really get more detail than like a quick blurb, you have to read it more than once because it is dense. And this is a real simplified version. Yes.
The map of the body is in the iris?
Yeah, let me continue with this because we'll have questions later if you can write them down. If you think you're not going to remember your question, go ahead and raise it. But if a lot of the questions last time, I've got slides to cover. So, but if you think you're going to forget it or it's really on what we're talking about now, go ahead and ask it. But yeah, if you look up iridology, Google's amazing. Look up iridology. A lot of people don't believe in it, but there's some truth to it. So age-related cataract. So there's death, taxes, and cataract. Okay? So cataract, if you live long enough, you're going to get a cataract. And if you have a vitrectomy, you're going to get a cataract. So we'll talk about that a little bit too. So vitrectomy we covered last time. It's removal of the gel. So vitreous, whenever you hear ectomy, like appendectomy, or if that means you're taking it out, you're getting rid of it. So vitrectomy is when you remove the gel. You can't really remove all the gel because it's stuck to the side of the retina. If you try and do that, you'll tear the retina. So back to cataracts, people, this is a common thing, like, why can't you transplant the eye? Here's another one that I'll try and clear up for you. I want to have laser cataract surgery. truly, it doesn't exist. There's one part of the cataract surgery that people have been trying to market with an excimer laser where you open up the capsule, but that's all you can do with the laser. But it is very nice because you can create a nice circular opening, but a good cataract surgeon can do that about 95% of the time with his hands. So if you are getting laser cataract surgery, that's the only part of it that is laser. The rest is done by a human and an ultrasound probe. And if you have cataract surgery, you haven't had it, they should talk to you about the different kinds of lenses you can put in. The standard lens has one focal point. So the conversation you should have with your cataract surgeon would be, what kind of lens are you putting in my eye? And then if you want special lenses that see near and far, we'll cover those in a sec. Those cost more. Same with the astigmatic lenses. If you have astigmatism, you can fix those. In the old days, first they didn't put in a lens and you had a big thick lens. Then we put in lenses and you can only have one focal point. So you had to pick near or far. So it wasn't true that you would have cataract surgery and you never need glasses. And that's still kind of true. Your best vision's almost always with glasses, but we're getting better at it. And a big incredible thing that happened is when we figured out how to make lenses you can fold, because then you can make a smaller opening to put them in and they unfold in the eye. So those are the lenses that you can get. The traditional monofocal. The toric lenses are the ones for astigmatism. And the multifocal lenses allow you to see near and far. The first ones that came out like 20 years ago, 30 years ago, were kind of, people put them in and a lot of people go, okay, this isn't good. Why? Because you're sacrificing the quality of each, both near and far, a little bit to get that. So people like, again, like if I share these slide sets, you won't have to worry about, you could study all this since you do have two eyes too. So here's the monofocal lens and how it works. It has different locations for different, kind of like, you know, if you have a bifocal, right? It has different locations for different distances and focal points. So you can tell when we examine people and, you know, we look at them, we can tell a monofocal lens is because it has these circles on them. So those will cost you a little bit more, but a lot of people's goals in life is never to wear glasses. And if that's the case, this might be what you want to do. So let's go over a little bit about what really happens in a cataract surgery. In the old days, we gave a shot underneath the eye to put it to sleep called a retrobulbar with like a 1 1/4 inch needle. And there's risks of perforation, there's risks of hemorrhage. And so then we switched to what's called a peribulbar, where you don't go as far back, but you infiltrate around the eye, and those kill the nerves function in the back for about an hour or two. Now, a lot of times they just use drops. So they'll ask you to move your eye around or hold still or during the surgery. So it's a little bit more pressure on the surgeon. And then we make an opening in the cornea, and now it's about 2.2 millimeters, which is great. In the old days, again, we had about a 11 millimeter to remove the whole lens in the, you know, like we call those intercaps where you take out the whole lens. And then we went to extra cap where it was about 10. And then we started doing phaco. Phaco's another word for phaco emulsification, means ultrasound. So when I was getting taught at the VA and I was doing my first phaco, there was a doctor named John Stanley, and you know, you're like going, what am I going to do to this person? He's going phaco, 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 you know. So, but the thing with phaco that happens with phaco, if things go wrong, is pieces can fall in the back, which hardly ever happened with extra cap. And that's called retained lens, and I'll show you pictures of that and the treatment for that. So you're basically making an opening. There's that opening that either the laser or more commonly we do by hand. That's called a capsulorhexis. So we open up this capsule that's holding the lens surface. That's going to be left behind, hopefully, if things go well, because you want to put a lens in. And then the idea is to remove all this lens substance. Both the nucleus can be very hard if you're older, and the cortex, which is on that. Whenever you hear cortex, it means it's on the outside, and the nucleus is in the middle. So that's cataract surgery, and here's the steps. So you take out all that, and you do that with a phaco, and then you use We call it the IA to remove the cortex, which is softer. And then hopefully you have a capsular bag left, which is true about 98% of the time in a good, cataract surgeon. But there's reasons that that may not be left. And then you're shooting you load up a lens that's folded in a cartridge, and then you shoot it into the eye and it unfolds into the eye all the way open like this. So it goes in and it looks like that, and then it opens up. And then you can position the lens. I think that's what they're showing there. Not sure what they're showing right there. But that's kind of cataract surgery, present day cataract surgery, not a lot of laser in it. So, so there's another lens, and that's how it's placed. These are called haptics, and that's the optic. And you're putting it in again in the capsular bag. Now the capsular bag, just like cataract, taxes, and death, posterior capsular opacity. If you've had a cataract surgery and the posterior capsule is intact, you're going to end up getting a posterior capsule opacity that needs to be lasered later. So that's more Medicare money for the ophthalmologist. They can bring you in and do
What is laser? Later.
it's a YAG, and I'll go over that, a YAG capsulotomy. Yeah. So, yes.
So after they put the lens in, do you suture it or does it heal by?
Usually you don't suture it. I'll show you sometimes where you have to suture a lens. If there's no capsular bag, how is it going to be supported? So in the old days, we put lenses in the front. That's called an anterior chamber lens. And nowadays, sometimes I've done this where you suture it to the side of the eye, and that's very tedious, but we do that. Okay, so cataract surgery, when you get a cataract evaluation, if you're not seeing well, they're going to want to take out your lens and put in a new lens. It's a very common surgery, but there are risks. But a lot of times people aren't either listening to the risks, or the surgeon just wants to take the cataract out. You won't hear what can happen. So you usually go from about 1 to 1,000 or 1 to 10,000 chance of a retinal detachment to about 1%. After you have that laser that we're going to cover, that's called a YAG laser, you even go up to 2 or 3%. So a lot of the retinal detachments I saw were post-cataract retinal detachments that, that's one of the risks of doing the surgery. And it doesn't happen during the surgery. It's nothing the cataract surgeon did, but by taking out the cataract and disturbing the lens material and everything, the vitreous liquefies quicker, and it pulls away, and smaller holes that may be present already in the retina can cause a retinal detachment. So that happens, but it doesn't happen right away. Retained lens is never a good thing. Like if, everybody has very high expectations now for cataract surgery. So when pieces of the lens fall in the back, sometimes they won't even put a lens in, and they'll send them to a retinal specialist. Actually, a lot of bad things that happen during cataract surgery come to the retinal specialist. The cataract surgeon is like, well, that didn't work out very well. I'm not going to get a bottle of wine. To retina you go. And so these are the things that we deal with all the time, is a retained lens. And that requires a vitrectomy, again, removal of the gel. And then you use a probe in the back of the eye, especially if the lens material is very hard, to break up the lens and suck it up and remove it so that's not floating around. If it floats around a lot, it can cause glaucoma and clog up the meshwork, because little pieces of the lens float around and they get into that drain and clog the drain. The worst problem is endophthalmitis, which is pretty rare now, because in the old days, we gave people drops of antibiotics after cataract surgery. Now we inject a little bit of antibiotic into the eye itself at the end of it. And the liquid that we're using to do the cataract surgery has an antibiotic in it to kill off bacteria. So that's been a huge deal. Like part of our job used to be dealing with post-cataract endophthalmitis, and people are unhappy. That's much rarer now. It's more common to have it from an injection, which is still uncommon, but you don't see a lot of them from cataract surgery. Yes, Jen?
Retained lens, what causes that?
I'll show you.
Okay.
Okay, so yeah, I'll get to all these. I have pictures of some too. Actually, one of the most common complications of cataract surgery is swelling of the macula. It's called macular edema, or CME, also known as the Irvine gas syndrome for the two doctors that discovered this. And it's occurs about 8% of the time. So you start out with good vision right after the surgery, and then about 4 weeks later, you go, it's gotten blurry, and we can do an OCT and show that in the macula, remember the macula means spot in Latin, you have a petalloid appearance of edema. And that's what these doctors long time ago before OCTs very carefully were looking at. They go, look at that, there's something going on there. They were just great observationists. And here's CME, and there's a lot of things that can cause CME. Inflammation without cataract surgery can cause CME. A lens that's rubbing against the iris causes CME. Anything that causes inflammation in the eye releases small prostaglandin molecules that float all the way back to the retina. And for some reason, the macula itself, the most important area, maybe because it doesn't have those inner layers of cells that are moved out so that the foveal pit can focus light better, but for whatever reason, you go from this here where you have a normal macula to a swollen macula full of fluid. And so that is treated with drops or a steroid injection, or sometimes the same anti-VEGF works too. Remember, one of the jokes at a retinal meeting is, okay, these are all the diseases that are interesting in the diagnosis. Now, what are you going to treat it with? You're going to treat it with an anti-VEGF injection, always. So, but there's a lot of ways to treat this. I like to use the steroid if they don't have glaucoma because it lasts 3 months. You don't have to do shots in the eye, and there's no risk of an infection in the eye. So yeah, it's hard to tell, but that little change in the spot there, and then when we used to do angiograms, it would leak. And we didn't talk a lot about angiograms because they're kind of going away. But that's what CME looks like in angiogram, and that's what it looks like on OCT. And what is retained lens? How does it happen? Retained lens looks like this to the vitreous surgeon. So it's sitting on the bottom of the retina, and it's because during the surgery, remember we talked about the cataract surgeons are not trying to find vitreous, whereas we're diving into it as a retinal surgeon because we work in the back. So when you break the capsule during cataract surgery, or you've had trauma, or you have pseudo exfoliation, which is something we don't have time to talk about, but it weakens the zonules of the lens and can cause glaucoma. Those or you have a small pupil and it's hard to see while you're doing the surgery, and you suck the capsule while you're not trying to suck the capsule instead of the lens. And so this falls to the back, and usually they have to come to your bedside afterwards and say, we're not done and you need to see Dr. Vitreoretinal surgeon tomorrow or soon. And so so what do we do? This is what a vitrectomy looks like set up. Okay, so vitrectomies are almost 50 years old now. The first group of people that ever did a 3-port vitrectomy were the retinal surgeons. So they use it in knees, they use it in the stomach now. So one is to create an infusion so the space you're working with stays inflated. One has a light so you can see what you're doing in that cavity, and one has an active tool. So that's a 3-port system, and it was discovered by, ophthalmologists. And so what we do is remove the gel, and then we remove that material back. Sometimes we'll have to put a lens in at the same time. And then here's a dislocated lens. Sometimes when the capsule breaks, it's a decision-making process for the general ophthalmologist. He's like, I'd hate to have to tell them that we didn't put in a lens. So they put in a lens, and it looks stable, sort of, we've been there. And you tap on it, you move it around, and you think it's going to be all right. And they come in the next day and it's dislocated or subluxated, means not all the way dislocated. And then it falls on the back of the retina, and that's what you're seeing right there is a lens sitting on the macula and the optic nerve. So again, they get sent to the retinal specialist because we go into the back, and we're going to pick it up with forceps, is what you're seeing here, and we're going to take it out of the eye. So problem is you got to make a bigger opening to take it out because it's unfolded, right? Or you can take a scissors inside and cut it out and take a small bit, It's not a good cataract, not a good result so far. You can end up with good vision, but you're not going to be the person like telling all your neighbors how great your cataract surgery was. And when, but there's a lot of those people. The other way to do it is you take an intraocular lens that's specially made, but usually it's not available at the time of cataract surgery problem, but for the retinal surgeons, we can order these. And you put sutures around it before you put it in the eye. You make a bigger opening because it's not foldable. and then you pull it, put it in the eye, and then you pull it so that it's well centered right here, and then you suture it to the side of the eye on the sclera. And that's kind of tedious. It's not my favorite surgery, but I've done quite a few of those too. And that when that first came out, that was a big deal because at the time, the lenses, the other alternative was put a lens in the front of the eye, and the lenses in the front of the eye caused a lot of CME, what we just showed you, that edema, because they rubbed against the iris. Because instead of sitting in the capsule, they're sitting on the iris. The question about the laser and the capsule. Okay, so this is when we look in and you've had good cataract surgery. There's nothing wrong with the cataract surgery, and 2 or 3 years later, your vision's getting blurry again. And we look in and it looks all pebbled like this. That's called a posterior capsular opacity. And the light is going straight through the eye. Like when you use the slit lamp, you can move the light around. This is retroillumination, where you can see the light from the retina is orange because of the color of the retinal pigment. It bounces off the back, and you can see that the lens has all this opacity that grew back after the cataract surgery was successful. This is how it looks without retroillumination. It's not clear. Okay, so this is sometimes called the secondary cataract, but it's not really a cataract because the lens material is gone. It's a posterior capsular opacity, posterior because it's in the back. And so the laser we use is called YAG. It's a yttrium laser, and it creates these little miniature explosions, and we have a little red dot, and we go around and we make an opening to clear up that. And that's more Medicare dollars at work. So, you know, I've never built Medicare that I know of. And now here's a picture of the YAG. And so again, the YAG laser is opening this capsular opacity so that the light can get through. Because remember, the front of the camera is just to focus it on the film, the retina, specifically usually the macula. And so this is creating a clear access for good vision. Yes.
Glasses clear up the fogging that happens.
No, because remember, glasses are focusing on the macula, but if there's opacities in the way, like a cataract or a posterior capsular opacity, usually not. There's that usually not for a posterior capsular opacity, but if you have a special kind of cataract, well, everyone has this as we get older, it's called nuclear sclerosis. And if you have pure nuclear sclerosis, your eye the lens can get very dark, like coffee colored, instead of clear. Like it looks almost clear or very, very light gray in a kid or a young person. And as we get older, it looks a little greenish, and then it can look brown. Like I've been in Nepal and took out cataracts, and they're dark, dark coffee colored, you know, like you can't, they're, you know, cataract nigrans means black cataract, and they're really hard. Those are some of the ones where they're trying to use the ultrasound, okay? And it's so hard that even with the ultrasound cranked up, they can't really get sculpting and remove the lens. And that's a common time where going to an older type of technique where you open up the eye bigger and you push the lens out like we did 25 years ago is better than forcing a new modern technique in a really hard lens. So yeah, you can't fix, but with a nuclear sclerotic cataract, because it doesn't have opacity, but increases the index of refraction of the lens, you get more and more nearsighted, but you can see almost pretty clear by changing the lens. So while you're waiting on cataract surgery, changing glasses sometimes can help if you're mostly nuclear sclerotic. So remember, nucleus is the center of the lens. As that gets harder, it's going to bend the light more and you'll become more nearsighted. So sometimes a cataract can be fixed kind of with lenses. Yes.
Right after my cataract surgery, I could pass the DMV vision test without glasses, but now I can't.
Could be a lot of things. Could be the retina. Hopefully it's a posterior capsular opacity, because that's a happy moment. Like you know, like a lot of times if you're the person doing the laser and you haven't done cataract surgery, you're the last one out, you know? So, and if you fix it, it's not like cataract surgery now, you can have it and not be patched the day of and go, wow, this is better. Like LASIK, some people, you know, you do the LASIK, you don't even need a patch and you're just going, this is incredible. But with cataract surgery, you usually patch it so you don't get infected. But with a YAG, you don't need a patch. So a lot of times people walk out and they go, oh my God, that is back to where it was. So yeah, you should let them look at, it could be the retina, could be the lens, but posterior capsule opacity is very common. Very, very common. We're going to talk about floaters. Jenna, yes, you have a question?
Is there something to protect the cornea? Because I had heard something about if you were predisposed to having Fuchs dystrophy, you may end up with that.
Yeah, Fuchs dystrophy is when the endothelial cells, which are the back layer of the cornea that touches that's closest to the pupil or the iris. So it's not the superficial layer, but the deeper layer of the cornea. Those cells are constantly pumping out water. And when they get thinned out in Fuchs dystrophy, which is a genetic thing, we think, and you can actually see it when you look on the slit lamp. Oh, those looks like, we call them guttata. They have a lot of guttata. And so they're prone, when you use an ultrasound, to losing some of the endothelial cells. So there's different, we inject these gels into the eye, like Helon was one of them, Amvisc is another. And you can use a thicker gel to coat the endothelium. You also want a cataract surgeon that stays in the capsular bag while he's doing the work and doesn't get it close, doesn't bring it up into the pupillary plane to do the phaco. Some people do that, where they tumble the lens up in the mid plane. So you just want a quality cataract surgeon to decrease the chance of losing more endothelial cells. If you lose more endothelial cells, you could need a transplant of the cornea, or usually now they just transplant the very back layer of the cornea, which is new and incredible. And instead of putting a whole new thing on, they float a little thin layer and put a gas bubble to hold it back in the cornea. So this is something that almost all of us probably have, floaters. Yes.
How does one know if a particular ophthalmologist has the up-to-date and complex knowledge that you're saying?
It's like, was it Herod or Pilate asking Jesus, what is truth? So I'm going to go to the next slide. You know, you got to ask around. It's very hard to know. Even I don't know. Sometimes people ask me who's the best cataract. If I've seen them do cataract surgery, I can tell them, like, I've watched them, you know, and they're really, really good. Some people have a great reputation, you know, that's usually really helpful and reliable. You don't want somebody who just came into the area who's 28 years old or something. You don't want somebody my age probably either. So floaters, we all have floaters, and there's a million different reasons for floaters. Okay, so the way to know why you have floaters is to get a dilated exam. And a dilated exam oftentimes will tell you why you have floaters and if they're serious or not. Most floaters are not serious, but if you have new floaters for the first time, you're sitting there. This is true of almost any symptom, but we've learned to ignore things because we're getting old and we have a lot of symptoms, right? You go, I don't want to go for this one because they're going to, you know, they're going to do things to me. But if you have new black dots with flashes that you've never seen before, and the next week you should be dilated and looked at carefully to make sure you don't have a retinal tear or retinal detachment. We're going to cover that now that we're talking about floaters, because oftentimes the big event is where the gel peels away from the back of the retina, just like Jenna was talking about. And that's so common that I'm going to, like, a lot of these things we're repeating because, again, to understand this is a dense stuff, it's just not going to, it's not going to be like The Simpsons or something where you can get it right away. And it's funnier, you know. So the posterior vitreous detachment we call PVD, and it's a normal aging event. Senuresis of a gel occurs over time. And as that does, your gel peels away from the back of the retina. And in certain people, especially with family histories of retinal detachment or tear, they can get a retinal tear or retinal detachment. And that can happen about 2% of the time. So most of the time when people call and say they're having a retinal or a new floaters, it's not going to be anything, but you have to come in and get dilated to find out. So this is like a diagram of the gel pulling away from the back of the retina. And that's normal. And because you have a bunch of collagen fibrils in that gel. It's 98% water, but there's collagen and proteins in there. Now it's collapsed and condensed, and you can see some of them easier. And also, there's the biggest attachment of the gel to the back is a fibrous ring. And when it pulls off, that's called a Weiss's ring or a Voigt's ring by the two people who described it first. And so a lot of people say, I see this circle or I see this figure 8 when it's kind of like bent a little bit. And that's the fibrous glial ring that was attached to the optic nerve before it peeled away from the retina. So this is another diagram or drawing of the vitreous attachment that shows the Weiss's ring coming off of the optic nerve and some of the new floaters, but it's oftentimes this one that people notice. And the reason I say a bunch of little black dots should get you in, that's more worrisome than seeing a big circular ring, because that could be physiologic, just the Weiss's ring pulling away from the back of the retina. But if you get a retinal tear, you're going to release cells from underneath the retina, retinal pigment epithelial cells, and they float in the gel. So one of the things we do when we look at somebody and we're worried they have new floaters, they come in, they get dilated, we look at the gel while they're sitting up before we lay them back and look at the retina. We look at the anterior gel, and if they have dark pigmented cells, we're really going to look hard in the back for a retinal tear. That's called tobacco dust. And that is suggestive that they might have a retinal tear. And that most of the tears occur, okay, remember the macula is way back here because it makes sense because the whole thing focuses light to the back, right? It's kind of a straight axis to the back. Retinal tears occur in the periphery. So you have to put on that funny thing with the, the light on it and to look, because you got to look in the far periphery. And sometimes they're small, sometimes they're giant. There's giant retinal tears. I'd love to show you a whole bunch of different kind of tears, but we don't have that much time to go over all the cool things in retina. But so this is a posterior vitreous attachment pulling on the peripheral vitreous dell, lifting an area that's adherent. Like, why do some people get in some do it? There's abnormal adherences in some people, and it doesn't peel away cleanly, and it pulls and pulls, and it finally rips through the retina. Then the fluid that's inside the eye gets underneath the retina and creates a retinal detachment. And it usually starts in the periphery as a shadow in the periphery. So what if you have, let's say you got dilated and we said, okay, you have a retinal tear, what do we do about it? Now that this is another thing about ophthalmology, when somebody says they had laser, which one? You can have laser for glaucoma, you can have laser for your posterior capsulotomy, you can have laser for retinopathy of prematurity, you can have laser for retinal tear. So this is a laser for retinal tear. And if you look really close, you say, well, why do they go so far around it when the tear is just right around here? Well, we're creating a barrier. And if you look really close, you can see that there's fluid right there. This is normal retina that's attached, and there's a little puddle of fluid here. So when you try and burn the retina, if there's fluid in there, it won't burn because the burn comes from the deeper layer, the retinal pigment epithelium, which is a brownish color absorbing green light. And you can turn it up higher and get some lighter burns in this area, but that's why that's a wider area of treatment there. And a lot of times we'll do that with a thing on our head that has a laser coming out of it. And we see a red light and we're pointing it in that area and we're stepping on the pedal. And if the eye moves, occasionally you'll get those little spots away from there. This isn't my slide. That was my work. This is off Google. So how does it look when you see them post-op? We'll bring them back and say, well, okay, well, what happened? Well, all those burns irritate the retinal pigment epithelium and they create a scar. And the retinal pigment epithelium can only do certain things. And one of the things it does is create pigmentation through hyperplasia. Hyperplasia means that the cells are dividing. They're stimulated by the burn. Hypertrophy means just the cell gets bigger. Hyperplasia means the cells are dividing and increasing. So what you're doing is the gel is pulling on this flap. This is called a horseshoe tear because it's in this shape. And there's gel attached oftentimes to this flap because the gel peels away from the back and it moves anteriorly. So this direction is the anterior retina, and this would be back towards the optic nerve. And that's the area that needs laser the most, and it's the hardest to get to because sometimes it's way out there and you have an artificial lens and you're trying to get a red spot to come through before you press the pedal and create a burn, it's sometimes real difficult. So you can see, but they did get a barrier there, and that's a pretty good sized tear. But that should hold it together, and it works pretty well. Now, here's a horseshoe tear causing a retinal detachment. And so remember, everything's upside down and backwards when we look at it. Everything that you see is upside down and backwards too. And so this would be, if it's on the top, you'll see a shadow on the bottom. And it'll start in the far periphery. So you see, if you're looking straight ahead, when you check for retinal detachment, you don't want to go like this. Do I have a retinal detachment? You want to cover one eye and look straight ahead. And if you see a shadow on the bottom, that tells you, and you don't have to, it won't move around like a floater will. A lot of times people get floaters confused with the retinal detachment. Just holding your eye still, you're going to see a black area or a darker, much darker area. And the reason is the sensory retina is detached away from the retinal pigment epithelium. So the camera, the film is separated. It's not going to work. It's not going to send a signal. And all this will. So there's a big contrast between attached and detached retina that you can detect, especially by covering one eye. And that's the thing I got to talk about. It's not a bad idea when you're having breakfast every morning, just cover one eye, see what's in it. Make sure you have a full field of view. Make sure there's no wiggles in it. You can use a door jamb. You can use an edge of a picture frame, and that kind of checks it. It should only take 5 or 6 seconds. And by covering one eye, you're removing the dominant eye from hiding what might be in the non-dominant eye. And you're also isolating each one, which is how we test you when you come in. So that's a little blurb for spend 10 seconds every day to just check your vision. Maybe not every day, but like 3 times a week. So if you have a retinal detachment, in the old days, this was the gold standard. It's called the scleral buckle. And what we do is we suture a silicone belt around the eye, and it gets sutured and creates an indentation. And then we scratch down on the sclera and stick a little needle in the area of fluid, and that drains out the fluid and the retina reattaches. Sometimes we'll add a gas bubble and have people positioned too. So scleral buckle can make you a little more nearsighted, but it will not cause a cataract. So, and you can add laser, but we usually freeze these tears before we drain the fluid out. And you get about a 90% success rate of reattaching the retina in one surgery. If it doesn't work, then you could do a vitrectomy. If that doesn't work, the chance of your good vision is going lower each time. So one of the causes of blindness is failed retinal surgery. And the most common cause of that is scar tissue forming, or just a bad surgery. And you need multiple surgeries. And by the time the retina has been beat up and you've had scarring and there's CME or cystoid macular edema in the macula, and all this is going on, sometimes you can get problems with your muscles because these go underneath the muscles. So scleral buckling is kind of going away because it takes more time. It's more of a craft. It's not the same thing every time. You can use different size of pieces. There's different ways to drain. It's kind of how I was taught along with vitrectomy, but the newer guys will use they'll use a vitrectomy, or they'll use a pneumatic retinopexy. I love the pneumatic retinopexy. So that is, let's say you come in and you have a tear at the top of your retina and you notice a shadow on the bottom. That means you have a superior retinal detachment. So when somebody comes in with a retinal detachment and they say, and I said, where's your shadow? And they go on the bottom, you're going, good. We could do this in the office. I don't need OR time. It will be a lot less painful. You won't need post-op drops. You won't have a change of shape in your eye and have to go to the optometrist. And you'll recover much sooner, and you'll have better visual acuity than the other 2 ways we fix them, which would be scleral buckle or vitrectomy. But again, a gas bubble rises, so it helps to have, it's usually the top 180 degrees where your tear is that we can do this. We've actually done giant retinal tears, and we published that from UCSF with a gas bubble, but that is more detailed. But you can do a lot with a gas bubble. And so what does this entail? It entails drops to get you numbed up, almost like Mark's going to go and he's going to have the drops put in his eye, and then they're going to do a subconjunctival injection to numb it up further. The drops were to numb it up so you can give that numbing injection. And then instead of injecting medicine, we're going to inject a gas bubble. In the old days, we used SF6 sulfur hexafluoride, or C3F8, which is perfluoropropane. We use those because when you inject them like 0.3 mLs, which is a pretty tiny bubble, you can't put in too much or the pressure goes way up in the eye and you'll close off the central retinal artery and then the vision will go dark. And if it stays closed off for how long? 90 minutes, the retina will be dead. So we'll inject, let's say 0.2 or 0.3 mLs of pure gas. We used to get these things, these were like refrigerators. They were used in refrigerators. So we get these in the canisters. And then Alcon got a hold of them. We used to pay like $50 and we get a canister and put a filter on it, no problem. Never had a problem. Alcon got a hold of them. They're like $3,000 now and they're highly regulated and stuff. So anyways, you inject this gas bubble and it'll expand after the first 3 hours. It'll double in size after about 10 hours. And why is that important? Well, you're trying to cover the gas bubble. The gas bubble is trying to cover this opening, because the opening's allowing the fluid to get underneath the retina and detach the retina. And if you can close the gas bubble, those mother cells will pump out the fluid. You can also show them how to use the gas bubble if they've got a superior retinal detachment to look down and then to come up and the gas bubble will sweep fluid out from underneath the retina back into the vitreous cavity. So there's a lot of stuff you can do with the gas bubble. And then the next day they come back and this is where you need some skill. You got to put laser around that thing. Sometimes we'll freeze it if it's a really small tear and we go, well, it'd be hard to find the next day. But oftentimes we'll reattach the retina and then you've got to put laser around that tear through the gas bubble. So that's where that's where you separate the people from the people. You can't say men from the boys anymore, are they? Okay, so vitrectomy we talked about is the 3-port vitrectomy. That's just like having a knee done, they have 3 openings, just like having a laparoscopy, they have 3 openings. And a lot of the people in this state actually developed this. The big scleral buckling was all done in Boston by a guy named Scapins, but then he stuck with it. And then Miami and California got into this vitrectomy, which ended up being like the huge growth thing. And so you can see, like we talked about 20/20 without the vitreous. Why is the vitreous there? It might be so that when you're developing your lens in your embryo, there's a blood vessel that comes out of the optic nerve and grows all the way up and forms a lens. Because remember, there's no blood vessels in the lens. So how did all that protein get there? Through the hyaloid artery, which grows out of the optic nerve during embryogenesis, and it forms the lens. And then it shrinks back down. So you can remove the gel without any problem and see 20/20. The problem with vitrectomy is you're going to get a cataract. So let's say you have a 25-year-old guy who's not going to get a cataract for maybe 45, 50 years. He has a retinal detachment. You have a young retinal surgeon that doesn't want to do scleral buckles. He's going to take out the gel, probably not put on a belt. Sometimes he'll put on a belt too. And then he's going to put a gas bubble in, a big, not a little gas bubble. Like if you go back to this one, that's about 20 or 30% of the volume. And because it doesn't cover all the lens won't dehydrate. And you won't get a cataract from a pneumatic retinopexy, which is another reason I like it. It's all an outpatient done and it's quick. And the hard part is you got to tell somebody, you got to lay like this, you got to keep your head up for 3 to 5 days. So that is the big challenge. So it doesn't work good in schizophrenics or people with bad necks. There's certain groups that you shouldn't try it with. So you're going to get a cataract. So if you have a retinal detachment and you do a vitrectomy, you're going to fill the whole eye with gas that dehydrates the lens. You're going to get a cataract. So that's we talked about. People equate quality with convenience, and so do surgeons. It's just convenient to do a 3-port vitrectomy. They don't have to pull down the thing. They don't have to have new glasses because you're not going to make the person more nearsighted, and they'll go face down for 7 days. So you're going to make somebody go face down for 7 days. They won't be able to fly in a plane oftentimes for 6 to 8 weeks, depending on which gas you use, but that's the way it's going. Let me know when we're supposed to break. Okay, we're supposed to break right now.
Yeah.
You guys, everybody, yes. Yeah, if you're doing a vitrectomy and use C3F8, and you do a full fill, you're gonna get a cataract. If you use SF6, you're gonna get a cataract, but maybe not as quick. But you still get one. Yeah.
When it's quick.
Quick, it depends on how old you are to start with. Like if you're young, if you're 30 and you do a vitrectomy, you may not get a cataract till you're 50, but that's still early. But if you're 60, well, I'll answer it this way. If you look at a lot of the publications I've done, they're on combining cataract surgery with retinal surgery, vitrectomy. And the reason for that is let's say you have a macular hole, which we're maybe going to get to this session. Macular hole is back in the macula and a retina. So we do a vitrectomy, you put in a C3F8 gas bubble the last 8 weeks, and you're going to have to go face down for usually 5 days or a week. Although there's been studies in London where people in wheelchairs, by just sitting up, they can close, but not as high success rate. So most people in this country, if you tell them you're going to get a better success, they're going to go, I'm going to go face down, and they'll do 5 to 7 days. But if you're 60 and you have a full vitrectomy with a gas bubble for a macular hole, usually within a year, you'll need a cataract surgery. So that's why we said, why don't we just do the cataract surgery at the same time we do the retinal surgery? That's what we did. Now, why hasn't that, even though we have the largest series published in the world for both macular hole and diabetes and macular pucker, which we'll get to, it's because you don't make as much money through Medicare when you do them together. And a lot of retinal surgeons don't want the extra responsibility of measuring the lens, talking to the patient about, okay, what kind of lens are we going to put in? You can't put in all those fancy lenses when you're doing that. So, but that's true even later. If you had a cataract surgeon do it, if you've had a macular pucker or retinal detachment, you have good vision. A lot of those other lenses won't work. A toric or an astigmatic lens will still work, but the multifocals usually aren't used in retinal diseases because they just don't work well because the retina is not fully functioning. And so the image tricks that those multifocal lengths are playing bother people with retinal disease. So combining the surgeries, and we not only did that, we removed the posterior capsule at the same time. So 2 years later, you're not going to need a YAG capsulotomy. Sounds like a good idea, huh? But because of, and I've been in retinal meetings where we also did this, okay? When diabetics, we'll get to this, when diabetics have bleeding, we need to put in a lot of laser in the peripheral retina. So a long time ago in Miami, there was a guy named Blankenship, who's a pretty famous retina guy, and he said, okay, what if we do 3 sessions? What if we do just one big session? What if we do half on top, half on bottom? He did all kinds of different ones, and he found at a year there was no difference in any of those groups. So what we did is one big session, because again, when you work at Kaiser, your goal is not to see how you can bill Medicare. And so when I go to a retinal meeting, some of the top people in this area, and they're really good, say, oh no, I split it up into 3 sessions. As soon as Medicare changed the way they reimbursed for you can't get paid 3 times, they all started doing it how we were doing it. So back to convenience and payment, not just convenience. Yes.
I'm not sure I heard you correctly when you were talking about the cups the way on, and you mentioned they were determined by race.
Well, African Americans will have a bigger cup to disc. And so that's why the visual fields and those other tests with the green or the red that measure retinal nerve fiber layer thickness, those are very useful because you got to make sure it's not glaucoma, because African Americans also have more glaucoma than other races. So yeah, and some white guys will have a big cup too that's physiologic, You guys are supposed to be doing something. Yeah.
At least by
Yeah, they have where you donate your blood and they take the serum of your blood. That might be the next step. Sure.
Yeah, we're late. I should now do an interpretive dance. Thank you. I just want to remind people that next Wednesday is Juneteenth. there will be no class. So the next time we meet will be in 2 weeks. Yeah, and if you haven't signed up for the class, please do in the back, or if you want to renew, I'll be there.
There has been a question from Zoom, is after cataract surgery, could you still use trifocals? And the answer is yes. No reason you can't, because you'll have a multifocal lens that gets rid of most of the power that you lost from your old lens, and then you can refine that with the trifocal or bifocal, and it shouldn't be a problem. So back to vitrectomy, this is the 3-port system. That remember, you're removing the gel. We call it pars plana because that's the area that God gave us to go in and out of the eye without tearing the retina. It's like it was made for that, just like the capsule was made for phaco emulsification, so that you know, once we figured out to leave the capsule, it's like the eye is set up for all these surgeries. So this is the infusion port. So that's gonna inject saline to replace while we're sucking with this thing, which is the vitreous cutter. So it can chop really fast, up to like 5,000 times a second or a minute. And then we have a light pipe, and there's all different. We can put scissors in there and forceps to pick up lenses with, magnets if there's pieces of metal in the back. So it can get pretty interesting. And there are different things you can add to the light pipe too, so that you have bimanual techniques where you have two things that can do something, active tools with light attached to it. And this is how it looks when we're doing surgery. We're looking at the eyeball like this through a microscope, and that's the setup with the infusion and the light pipe, and usually a dominant hand, right? If you're right-handed, the vitreous cutter. Here you can see they put a gas bubble in the eye, and it looks like it, or maybe that's just the lens there. But so you're removing the gel, and you can't remove it from the edges here because it's fused to the anterior vitreous base near the pars plana, or you'll create a giant retinal tear. So if you do that, you'll find that out. And this is used for all kinds of stuff: a retained lens, a macular pucker, or a macular hole, a retinal detachment. So that's why pars plana vitrectomy has become the kind of gold standard for most vitreoretinal surgeons. But there's still a lot of scleral buckling going on. We do other things too, like draining choroidals and removing foreign bodies. Yes.
Excuse me, so let's say on the right, how many persons are there in that surgery?
That's just one person. So you're using both your hands, and then you're using both your feet. So one of them, but it's nothing like playing the harp or the organ. Like I saw the Brandenburg Concerto or something on the organ. That was insane. But your right foot is going to control whether you're cutting or sucking, and you can just suck or just cut. You do a little flip to the right or the left. And then on your left foot, you can zoom in or zoom out, and then you can also focus in, focus out. So, you know, you get used to driving after a while, just like a drummer gets used to it. And after a while, you're not thinking about it.
Stationary, those.
This is stationary, yes. Yeah. A good question, yeah, because there's no assistant holding this. In the old days, we sutured this on. Now, that was a 20 gauge. So I started in 1991 at Jules Stein. We used 20 gauge instruments. When I left Kaiser, we're using 25 gauge, which is the higher the gauge, the smaller it's inverted. So it's much smaller. And now when you put them in, you go through the sclera on a bevel, like a diagonal kind of level, and then you go in, so it creates its own seal. So usually we don't even suture these anymore. In the old days, we brought down the conjunctiva, we sutured it on, and then we sutured these up, and then we sutured the conjunctiva. Now, this is why people aren't doing scleral buckles anymore. Now it's boom, 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 and the microscope comes on and you start operating. So you know, you can do a macular pucker where you're removing scar tissue without having to do a cataract surgery. You can do that in like 30 minutes now, whereas very rare to have it that quick in the old days because you had to suture at the end. So any questions about vitrectomy? Because there's so much to talk about vitrectomy. I could show you videos and you would be going, oh, wow. It's beautiful because, you know, you have this orange retina and there's stuff happening there. And it's like, that's the center of the eye, right? You're there and you're moving around. You don't want to move in the wrong area because there's dire consequences. So it really keeps your attention. Yes.
So to that vitreous humor, it doesn't come back again.
No, it'll be replaced by your aqueous and you don't need to see it better than 20/20. And if you put in a gas bubble, the gas bubble will go out slowly and then it'll be replaced by the aqueous humor. Yeah. So that's most modern day retinal surgery. It's a 3-port system. It causes cataract if you don't already have your lens removed. And then if you do a retinal surgery with this and it doesn't work, the scar tissue that you form in general from those surgeries is much harder and much more difficult to fix than a scleral buckle. And then sometimes you need to add a scleral buckle. So that's why a lot of us old guys still like scleral buckles. So remember, we said the 4 things were cataract, diabetes, macular degeneration, and what was the other one? And
Taxes.
thank you. Okay, taxes. Taxes are always on my mind too. So actually, the second most common type of retinal vascular disease is retinal vascular occlusions, usually caused just by garden variety hypertension. So I can't tell you how many people I've seen that have these occlusions in their retina that are going to potentially blind them. And when I tell them, let's measure your blood pressure and it's 150/95, and they go, oh, I've got white coat syndrome. Well, then you also have driving on 17 syndrome. And you also have driving on 1 syndrome. And you also have argument with your spouse syndrome. So those are real numbers. Question is, where are you most of the time? But retinal vascular occlusions are a big part of a retinal practice. And there's a branch, and that's caused by arteries and veins in the retina cross. And when the pressure's high in the artery, it presses on the vein, and that they're already slower flow in the vein, and that causes the blood to coagulate, and you get a branch retinal vein occlusion. The central retinal vein occlusion is a whole different beast, because remember we showed you the anatomy where the central retinal vein and artery go through the optic nerve, right? The artery is feeding the retina, and the vein is draining out stuff. So it's just like waste management. The vein is waste management, removing the blood after it's been deoxygenated and things have been delivered. So the one risk of the central retinal vein occlusion that you don't see with branch retinal vein occlusion, again, is sleep apnea, hypertension, glaucoma, also because the glaucoma is changing the shape of the optic cup and the optic nerve. And by doing that, you can press on the retinal vein and slow down the flow and create a clot too. So the big causes of central retinal vein occlusion are high blood pressure, sleep apnea, glaucoma, and diabetes causes everything. And then retinal artery occlusion are usually caused by little pieces of emboli. We call them emboli when they travel from the carotid artery up through the ophthalmic artery into the central retinal artery into a little tiny twig of the retinal vascular system of the retinal arteries. So if you've ever had a TIA, that's called transient ischemic attack. If you go to the ER and tell them, I just had a shadow come down for about 20 minutes where it was like a shade come down, and then it came back, they're going to look at your carotid artery. That's a classic TIA symptom. There's a lot of stuff that aren't TIAs that'll still get you a workup because, descriptions and how people interpret your descriptions are going to be different. So let's look at this. So this is why you should treat high blood pressure. And a lot of people tell me, well, I'm going to do more yoga and I'm going to, exercise more and I'm going to stop eating, the chips and whatever it is. Like a lot of it's genetic. Like I was doing yoga and playing soccer and everything, and my blood pressure would be like 150/95, and that means you got to take medicine. And believe me, I don't want to take medicine. But I've seen you can get renal disease. You can lose your kidney function from just blood pressure. So any place in the body where we have tiny blood vessels, hypertension can damage. So what are those places? The brain. Okay, so the most common form of dementia is white matter infarcts. That means your blood pressure is high and you're damaging little parts of your redundancy in your brain that you don't notice for over many, many years, right? And gradually, if you do an MRI of a 20-year-old, an MRI of an 80-year-old, there's a lot of space between the brain and the skull in an 80-year-old, okay? It's just the way it is. It'll be worse if you have hypertension. So hypertension is something you really gotta, it pays to have one of those little cups at home and keep exercising and yoga and all that stuff. But sometimes you just got to take your medicine. And a lot of people that rely on the natural ways are people that end up getting renal failure or retinal vein occlusion. So when this artery is placed on the vein, it slows that flow and you can get a clot. And this is what it looks like. So right where this artery is crossing the vein, it's pinching. Remember, the vein flows going this way, back into the optic nerve, right? So what happens when you dam a river is first the river gets a little tortuous. So we see that in central retinal vein occlusion, and then it overflows its banks. Okay, so at first the pressure might just be enough where you get a little fluid, but then it'll start popping the arteries and you get bleeding. And these are called cotton wool spots, and you can see why they look whitish. And those are microinfarcts. That means part of that retina is going to be dead. And there's non-ischemic retinal vein occlusions, which mean you're not going to kill the retina, but you could still get CME, cystoid macular edema, our best friend, caused by so many things. And this is one of the things that causes macular edema in the center of the macula. These are, what are these treated with, group? You should, the injections. Yeah, there it is. So this is, and why? Because a bunch of VEGF is released when this happens, because just like Jenna said, when you have low oxygenation, the only response we seem to be able to do is like, let's make more blood vessels. But when you already have the circuit made, they don't help, right? And VEGF not only makes new blood vessels grow, but it makes things leak. Yes.
So when you damage the cells in the eye, are they regenerative? Can they actually, go back?
Not a lot. It depends on there's such a big spectrum. There's mild, moderate, and severe. Severe is completely ischemic, and 90 minutes of ischemia in the retina or low oxygenation, it's dead.
It's dead, but I'm saying, so look, can they be replaced by new, like the skin?
About 15 years ago, what was the buzzword? Stem cells. We're going to give you stem cells, but hasn't really worked out. Yes.
Is that what there's
Anti-VEGF is one. Lucentis is one of the anti-VEGF. Yes. Yeah, it depends. Like some vein occlusions in the old days, we give light laser too, and they'd recover. They didn't need any shots before we had shots. Some of them went down to count fingers, which would be legal blindness. Well, you have to have both eyes for legal blindness, but that's bad vision. So we usually treat these with injections. Sometimes I'll add light laser. In the old days, we lasered once, lasered twice, and sometimes 3 times, because if you got a hammer and there's a nail and that's all you got, that's what you're going to do. But burning the retina is irreversible, whereas the shots wear off and they don't seem to like people ask me, how many shots can you get? Oh, probably one every 4 weeks for the rest of your life. And you say, well, how can that be? Well, just going to different parts of the sclera and it'll heal up. And then 6 weeks later, we'll do it again. And yeah, when the medicines first came out and we thought this is great, but then we realized, so we're going to do this every 4 to 6 weeks, just like you're looking at me right now. And you're like, yeah. And you're going, oh my God. So this is another branch retinal vein occlusion. You can see where the artery is pressing on the nerve right there. And the hemorrhage is occurring. And then this doesn't happen quickly. This is cholesterol. And it doesn't mean the patient has high cholesterol. What's happening is you've blocked the flow back. And so things are spilling out on the edges of the river, right? And some of those things are fluid. And in the fluid are molecules. And remember, the mother cells are pumping out fluid. So the mother cells are pumping out the water quick. H2O is a small molecule. But the bigger molecules of cholesterol don't get pumped out quick. So this is like a bathtub ring of cholesterol. And we call it exudate, but it's cholesterol basically. There's a little cholesterol up there too. And that means the process has been going on for at least a month or 2. And that, if it goes into the center of the macula and there's a big yellow spot there, that happens to a lot of diabetics. Even if you dry them out, it's toxic to their photoreceptors and they won't recover vision. So this one you would inject with Lucentis or, Avastin or BioViz or any of those. And you'd have to do it repeatedly probably. And sometimes you can do laser and too, but the mainstay is those injections. Now, this is something that a first-year resident can diagnose pretty quickly. When you look in the back and you see this, and there will be hemorrhages in all 4 quadrants. So remember that the central retinal artery and the vein are traveling in the very middle of the optic nerve. And either blood pressure or glaucoma, this doesn't look like glaucoma because there's a small cupped disc. So it could be hypertension, could be sleep apnea, could be a number of things, I guess. But what is this right here? This is ischemic whitening. So this means they have a ciliary retinal artery that closed off with the central retinal vein occlusion. And it's not from an embolus, and it takes a while to explain that even to residents, and it'll take them a while to understand it. But this is a special kind of central retinal vein occlusion. But here you can see the cotton wool spots. Do you see the dilated, plump veins there, you know, compared to like normal size veins, like right here? These are very dilated and plump, and then they spill over. So tortuous, thick veins are a sign of impending central retinal vein occlusion. This is a full on central retinal vein occlusion. So these are pretty common. They're not as common as diabetes causing problem, but they're pretty common because hypertension is pretty common. So in the old days, we would do scatter, not for the leakage, but if they had neovascularization. What is neovascularization? Neo is new, vascularization are blood vessels. So again, what do you need to make new blood vessels? VEGF. VEGF is an important chemical in the eye and the whole body, and very important in embryogenesis. But so if you have neovascularization, the gel can pull on those blood vessels, grow out of the retina, and make them bleed into the vitreous. So that's different than the swelling that we looked at from CME. Okay, this is blood in the gel, and that can really make it blurry because it's blocking the light from hitting the retina. So even now, we will treat that with laser. Maybe the first day we see the blood, we'll give them a shot so that the blood vessels shrink back. But once you stop giving them shots, the blood vessels just start growing again because this area has been damaged. It's an ischemic retinal vein occlusion. That means the blood flow is closed off and killed enough of the retina, and the retina is going, I need oxygen. And it's not getting it, so it makes new blood vessels. So you treat that with VEGF, and then later on, what you do is burn it to put it to sleep and say, all right, you're not, if you did a visual field on that area, they're not going to see out of that area. So you're not, if the laser is done correctly, you're not going to, this isn't my laser, it's kind of close to the macula, but you're not going to see out of it. So you're sacrificing very little if the laser's done the right area to kill off the retina that's crying and creating new VEGF. So that's what those burns look like. They're little white scars, and then they'll turn into those black spots later because of the retinal pigment epithelial hyperplasia. And these, I guess, they're showing the areas of neovascularization that they did the laser for. In the old days, we had to look through our butterfly collection and find our own cases for all these things. And nowadays, you go to Google Slides and it's very simple. So this is from University of Iowa, which evidently is one of the, I interviewed there for retina, and they were above Jewel Stein, and believe it or not, even though I was a California kid, I was going to go to Iowa. And when I interviewed there, the guy goes, a lot of the riffraff moves out when it goes -20 here, and he's looking right at me. And anyways, they didn't match. So, so this is a central retinal vein occlusion, very dilated veins there, cotton wool spots, swollen optic nerve. And this is something that when you get more experience, you can tell he's got a swollen macula there too, which is expected with this kind of a process. So this is a very easy diagnosis to make. In the old days, we didn't know how to treat it. So a lot of people lost vision to this. Now with the injections, people do pretty well. There's a common problem now though, because there's a spectrum of these. You can have 20/20 and have a central retinal vein occlusion with hemorrhages 360, maybe even a cotton wool spot or two. Some retinal specialists won't treat that. A week later, their vision goes down to count fingers because it's evolving, okay? The clot started and the retina hasn't been, damaged too much yet. So I like to treat any central retinal vein occlusion to prevent that with just at least a few shots. Okay, let's talk about artery occlusions. Okay, these aren't related to blood pressure as much. They're related to our aging, which is formation of atheromas or plaques in our arteries. And they can also be related to more esoteric things from the heart. Like young people can get these if they have, myxomas in their heart, which is an unusual tumor in the heart. But more commonly, maybe a calcific valve, a piece of calcium breaks off, and it has to get through a lot of areas, but the reason it shows up in the eye is because it's pretty small piece, and what gets into the very tiny blood vessels, again, the kidney, the brain, and the eye have very tiny blood vessels. So diabetes and emboli are a problem, especially in the heart, or not the heart, but the brain and the eye. So I like to say that a vein occlusion is like a crucifixion. It's slow. The onset, you're not going to kill right away. It could take weeks, and that's why people don't treat some of the 20/20s, but then it gradually does its thing. Sometimes it'll resolve without death. Whereas an artery occlusion, and nobody knows, like if you ask somebody with a central retinal vein occlusion, you say, when did it start? And they say, well, like 3 months ago, it kind of got dark for like an hour or two, but then it came back. I felt like it was normal for a few weeks, and then it started doing that, and then it back and forth. But with an artery occlusion, you'll know exactly when it happened, because remember, it only takes 90 minutes. If you close off the blood flow, they're going to notice that, especially if it's near the macula. So there's a sudden loss of the visual field. And in this case, if it involves the macula, they won't be able to see out of the eye. So most people notice this, especially if it's in their dominant eye right away. So this is a Hollenhorst plaque, is a name of another guy. And there's another one down here. And so then we'd send this guy to get a look at his carotid. Now, there's a lot of things that people try, breathing into bags, taking a little fluid off the front of the eye to suddenly lower the pressure, massage where you press on the eye and then let go to try and get these emboli to move downstream, but none of them work that well. There's been some really aggressive, like these are academic places because nobody in practice could do this, where they send you to a interventional radiologist and they go up through the carotid and through the ophthalmic artery and put in TPA through the ophthalmic artery to try and deliver to open this up. And there's some success with that, but it's such a unlikely thing to be able to get, even with the best of insurances, that unless you're doing somebody that's doing that study, that's not going to be a treatment. So remember, you got 90 minutes. So this is usually kind of vision like this after it's all over. And then maybe like this, and if they're lucky, the big E. So this can be devastating, and it wipes out stuff pretty quickly. And those are cholesterol plaques, the Hollenhorst plaque. This is a calcific plaque, and that's stuck there, and it's blocking the arteries here, and you can see all the ischemic whitening here, and it's just swelling the retina in that area. And so this, when you see it's whiter, and it doesn't, the Hollenhorst plaques, they're refractile, and they kind of like, when you shine light, they kind of shine it back at you, and you can tell the difference between the calcific ones look duller and they're whiter, and the Hollenhorst are kind of yellow. Here's another example of a branch retinal artery occlusion. Now, this patient may have 20/20 vision, but it's going to be split. And and if it's their dominant eye, you're going to hear about it because it's going to bother them a lot. And they may recover, but it's going to be months before you know how well they'll see. So again, this is the carotid artery, feeds up here, goes into the ophthalmic artery, and then goes to the central retinal artery. And that's how they get there. You got 90 minutes. And this is again, a first year resident kind of thing. This is called a cherry red spot, and this is horrible. But the reason that's there, again, that's why we went over anatomy first, is the nerve fiber layer has been moved out of the way so that light can focus on that foveola, right? The center of the macula is called the fovea. So this is all swollen nerve fiber layer, but there's no nerve fiber layer right in the middle. So what you see is the color of the retinal pigment epithelium coming through, and that's called a cherry red spot. So this is a central retinal artery occlusion with a cherry red spot. And the chance of good vision here is pretty low, but occasionally they can get lucky. So diabetes. I'm a borderline diabetic because I love sugar. And so, if your feet start getting hot when you're 40, I thought it was, I'm a doctor, but I'm kind of stupid. And I was like, these new shoes are, because they are thicker, right? Like the Nikes and stuff. And I was thinking, I'm sitting in a theater. I remember this, starting to take off my shoes when I'm going to the theater with my kid, and it didn't occur to me that having a slushy or an icy with like 3 or 4 Reese's cups could be related. So if your feet are getting hot, consider that you might be a borderline diabetic or a real diabetic. So it's a very common cause of visual loss in young adults and old adults. I think that was meant to be old adults, but type 1s. So when you have diabetes, you know, you have hemoglobin A1C as a measurement of about 90 days of your sugar level. The eye is kind of like your entire life of your sugar level. So you have to have kind of high levels for a long period of time for it to show up in the eye, but it'll usually eventually will show up. So type 1 presents, you know, suddenly because the viruses damage their pancreas and then they stop making insulin and they get extremely sick. And I remember being an intern in San Antonio, and there are a lot of Latinos there with diabetic ketoacidosis, and we would slowly bring down their sugars from 600 or 800 back down, you know, to 100. And it takes all night because you don't want to do it too suddenly. You got to hydrate them. So you're drawing blood the whole time. And it's how you learn about that. And the young people will know exactly when their diabetes starts. So if we have a type 1, they don't need to have their eyes looked at for a couple of years because we know it started then, and they're not going to have any changes in their eyes for a couple of years. The type 2 is a whole different thing. I've seen people with type 2 that worked in the operating room that handed instruments to a general surgeon, a friend of mine, and he came to me and he already had blood in his eyes and he was already in kidney failure to find out he had type 2 diabetes. So once you find out you have type 2 diabetes, you need to be dilated pretty soon, you know, within a month or so, because you don't know how long it's been going on before that, because there's kind of, it's a slow onset and you know, you just think there's a problem with your sneakers sometimes. So let's see. Yeah, so we have different levels. There's background is what we used to call it in my day. Now they call it non-proliferative. Proliferative means there's new blood vessels and they can bleed. Background's milder, but you can have macular edema without having proliferative and need shots for the macular edema. Same kind of shots, same treatment as usual. Yeah, and proliferative, we usually give the shots when they're bleeding, and then once they clear up, we give them laser, because that's an instance where the old school thing's still being used because it really stops the bleeding. And also if they're going to need a vitrectomy, which some of them do later, if the shots don't work, you want the retina tacked down a little bit with scars so that they don't have a detachment. So,
Like you say,
yes.
Takes years to develop and it takes a long time. What do you mean? I mean,
It's
10, 20 years?
You know, like I always say, it depends. Like everything in medicine seems to be mild, moderate, or severe. So if you're running a hemoglobin A1C of like 12 or 13, which means your average glucose is maybe in the 300s, I'm guessing because I'm not an endocrinologist, but it's very high. You're gonna show up earlier. Whereas if you have 10 years and your hemoglobin A1C is 7, you may not have anything in your eye yet. So it's very variable. But the one thing I'll tell people when I look at their eyes and they don't have anything, I say, good job. You don't have anything yet, especially if they've had it for 20 years. But if they only had it for 2 years, say, just because you don't have anything now doesn't mean you're baking it in, because it will show up. That's one thing you learn in medicine. You don't get away with anything. All those Reese's cups and Slurpees, they end up showing up. So, and I knew that, but you know, so non-proliferative, you can have cotton mole spots and hemorrhages. The hemorrhages will be inside the retina. Little microaneurysms, these little red dots that we used to shoot with the laser when they had macular edema, but you know, we'd shoot for the microaneurysms. And the hard exudates, those are the cholesterol that we just showed you in the branch retinal vein occlusions. So this is, you know, if you understand vascular things, they can only do so many things. And then the reason it's vascular endothelial is the inside of a blood vessel is called the endothelium. And on the endothelium, you have pericytes that they're kind of like the mother cells of the blood vessels, and high sugars damage those. And so they're not, they get sick. So diabetes is a disease of your blood vessels. Somebody asked, how can you have good health? Keep your blood vessels healthy, because diabetes affects everything, you know, brain, kidneys, feet, balance, mentation, everything. So this is what we call pan-retinal photocoagulation, or PRP. Pan meaning the whole retina, but it's not really the whole retina because you don't want to laser this area. That's the center area where you see, you know, from you. So this is tighter than I usually do it. You know, like I'll maybe go here and then go farther out because you know, you won't notice if you miss some of the peripheral areas. And the peripheral areas, because they're smaller and smaller branches of blood vessels, if you get those first and you can get rid of the blood vessels, then you haven't lost visual field. But it's pretty unusual to do laser in a bleeding diabetic and have them come back and say, hey, I don't see on the side as well as I did after laser. Why? Because it's already dead. You know, it's already not functioning well. So that's called panretinal photocoagulation. If that doesn't work, then you go to vitrectomy. And I could show you some really cool videos sometime of, like, just put in traction retinal detachment. Those are all these blood vessels growing out of the retina, all over the retina. Then the gel lifts them up and then tractionally detaches the retina without a tear. And then you get to go in and it's like, you have to find all the right tissue planes and dissect that all away. Okay, so I think we're going to stop here and we'll start back on diabetes. And if you guys have any questions too,
Yeah.
you can. Sure. Yes.
Question, I've been told that when I get these, kind of, they're not floaters, they're kind of, wavy lines that come into the side of the eye.
Mm.
And I was told years ago that it's an ocular migraine and take 2 aspirins, you don't get a headache.
Yeah.
20 minutes later.
Migraine is kind of a, there's classic migraine where it occurs in both eyes and you have a very jagged pattern that moves from the outside to the inside and, you know, oftentimes followed by a headache. And there's so many variants. So if you have something with flashing in your eye with or without a headache, and we don't find a retinal tear, we're going to tell you have a migraine and we're done. And, you know, it's because we've seen enough of them where we're not worried, well, you're going to have a brain tumor or something like that. But there's a lot of variants. Like some people don't have those classic symptoms that I just told you, but they have enough of them and we don't see another problem. So I think it's a little bit of a, you know, like, okay, we'll put that in the migraine category, but a lot of stuff we can't really identify. There's something rare called Moore's flashing lights, which is kind of an old term for people that came in and complained of flashes, but we didn't think they were migraines. And there's people that we think have vitreous traction, because if you press on your eye mechanically, you're creating phosphines. So that's why when your gel is pulling away from the retina, it's tugging on the retina, you get flashes, because you're mechanically stimulating it, but there's no image, so you see a bright flash. So some people think, okay, well, the people that have flashes, they have pulling on their anterior retina and it's creating these flashes, but we don't really know is the answer to that, I think. Yeah, because if you don't have typical and you don't have the headache, then we're not sure. And there's some people that think you can even get an artery occlusion from a migraine from the spasm of the blood vessel. But that's kind of controversial and I'm not so sure about that.
Yeah, there's no colors, so it's not
Yeah.
lights. It's just frequencies.
Yeah.
And it's both eyes at the same time.
Yeah, that I think that's fair to say it's a migraine variant.
And floaters, sometimes I don't see them at all. And sometimes.
Yeah, those might be that you're noticing the flashing and they're not really associated with the flashing, but when you're starting to look around and going, what is going on, that you can see your floaters a little bit. So that's the common thing in the eye is there's a difference between sudden onset and sudden discovery. It's like a woman putting on makeup in the mirror goes, oh, wait a minute. Oh my God, there's no vision there. But the reason it didn't just happen. The reason she just found it because she covered one eye, you see? So that would be sudden discovery. Sudden onset is like the artery occlusion. You're sitting in the middle of your day working on the computer and you go, oh my God, I just lost vision. That's, you know, that's sudden onset. Yes.
What is asteroid hyalosis?
Asteroid hyalosis is interesting. Like, I think we talked about that last time, but it's like the snow globes in Christmas that you shake up. When we look in, they look like that, but a little yellowish, okay? And the weird thing, a lot of people with asteroid, if you ask them, you say, do you notice floaters? And you can barely see their retina. There's so many floaters. And they'll go, no. So why is that, okay? That if they come on slowly, the brain cancels them out. And they're somehow see around. So that's a big lesson in medicine. Like a lot of the truths that you can find out just in the eye correspond to life. Okay, what if you go from a really cold walk outside for hours and then you come inside and it's 65 degrees, you're going to think it's like, oh, this is so great. Because so the body and the brain are impressed by contrast. And if things happen slowly, the brain can process some of those things out, especially if you have a personality that isn't like, I know I can find that, it's going to bother me, you know. But I mean, some people with asteroid will say, oh yeah, I got floaters, but not like the people that just have a few floaters that you can't see that are complaining bitterly of floaters.
Where did they come from?
It's associated with diabetes, but it doesn't have to be related to diabetes, and we're not sure why some occur. There's a thing called scintillans, which are after a bleed in the eye. There's cholesterol left over, which is a subset of like unusual floaters that you know is kind of a garbage bag kind of thing to put in for floaters. But asteroid looks pretty little yellow dots that are floating all around the retina. And a lot of times we'll have to do an angiogram to evaluate their retinas or an OCT because we can't see clinically through it. Yeah, but usually not a reason to do a vitrectomy, but sometimes if we're going to do a cataract, a lot of times, and I had somebody with dense asteroid hyalosis, we would combine the two surgeries in that case. So yeah, looks like a snow globe. It really does. Yes.
From your description, it appears, or it seems to me that there's been a lot of development of new techniques, new understandings, diagnoses, and so on in recent couple of decades, say. How is it that people who've been in private practice, say, for 20 years or so on, become informed, knowledgeable, and experienced with these things?
Well, continuing medical education. And, you know, there is a sweet spot we were talking before of age for your surgeon or your doctor. If they're too young, they're going to glam on to the next new technology that hasn't really stood the test of time and embrace it too heavily. If they're too old, you know, they may not even know about it, but you know, that's what, like we have a thing called Audio Digest where you get all these talks and you can get like the best new talks, and it's all the people in, you know, in the academic world or the influencers in private practice who sometimes have like a 3 or 4 page list of consulting for the drug companies or the device companies. So you have to keep that in mind, but they're also the people on the cutting edge of the technology. So a lot of people are very pro technology, you know, and some of the technology has been incredible. I'm a little bit more of a Luddite. Like when we did vitrectomy and we first did it, we had these lenses that you had to hold on the eye with irrigation or you sew on lenses, and they had a smaller visual field. So we were doing vitrectomies and seeing portions of the eye, and they came out with this thing that you had to put on the, you know, you got to put it on the microscope, and then it's you got to get an inverter, and then you bring it down and it's a wide field view. And I was reluctant to try it, but when I finally did do it, I was like, damn, I should have gotten this like 5 years ago. But what I was doing was successful at the time. So if it works, don't fix it a little bit. But I tend to not be the first guy to buy a flat screen TV, you know, when they come out, that kind of thing. So there's a happy sweet spot there, I'm sure.
Thank you.
Yeah. Any other questions? Okay, we'll meet back here in 2 weeks. Have a good Juneteenth.